this is a great place to be in, and you're welcome for this show.
All right. That's great. Just as a side, is it PCA Kikuyu Hospital or Mission Hospital?
PCA Kikuyu Hospital.
Where did the word mission go to?
It is still a mission hospital
Yeah.
within the church, which is the Christian Health Association, but I think that's just in terms of brand position or brand name standardization. So we call it PCA Kikuyu, but we know it's a mission hospital. Yes.
All right. Great, good. There's a part that you usually like to say about yourself with plus 10 years of clinical experience. You forgot that today.
Actually, I am a healthcare leader with over 12 years of experience
Yes.
in the Kenyan healthcare space.
Yeah.
And besides being a surgeon, which I've just mentioned, I'm also a public speaker and a distinguished Toastmaster and author. My book is titled The Chronicles of a Village Surgeon, which you can pick off the shelves from Muria store. And I love advocacy for health.
Yeah.
In Kenya and beyond, and especially advocacy for surgical systems that are responsive to the needs of the common lay person. And I am involved with the leadership of the Surgical Society of Kenya.
Yes.
I'm the present Honorary Secretary of the Kenya Surgical Society, or the Surgical Society of Kenya, which is the fraternity or umbrella body for all the surgeons in the country. So yes, that is the other plus 12 years of experience. Yes.
All right.
Yes.
Yes. Now let's get slowly into the talk of today, the discussion of today. As a surgeon, there's a way that you view a human being. All right. Interestingly, it's inevitable.
Absolutely.
When you see a human being, what do you see?
I see a creature, first and foremost,
Yeah.
with two main components, with structure and function. That is human, structure and function. And if you want to break it down, structure is the anatomy. So every human has one head, which has two eyes, which has two ears, which has two nostrils, which has a mouth, name it. So there is a way in which human body is composed, that is the structure or the anatomy. And there is a way in which it should function. And that is the second bit, which is what we call physiology in medicine, but it's really the structure or the functioning of the human body. So as a surgeon, when I look at a human, I see structure and I see function. And if any of those two go wrong, then you can't see the surgeon. That is why sometimes you find me calling myself the human mechanic. So when the structure has a problem, you come to the mechanic to fix the structure.
Yes.
And when the function has a problem, some of the function can be corrected without surgical intervention, but some of the physiology might be corrected with surgical intervention. So those are the instances in which you come to the surgeon.
Yeah. I asked that question, for example, if it's a pastor, a religious leader, there is a way they look at a person like, you are God's child.
Amen.
And you have a purpose on this earth.
Yes.
So different professions have a different way of looking at people. Well, now, that is the general person, but today we are talking about the health of man. First of all, who is a man? I mean, let's not go into those controversial things, but in simple words.
In simple terms, a man is a human who takes a certain form or body form and subscribes to certain societal responsibilities, if I have to put it that simply. So that a man is not just in biology, which is the makeup, it is also the assigned responsibility and space in society. But as a doctor, when I see a man, I look at a person who has got, in the structure I spoke about at the beginning, certain components that can render them susceptible to certain disease processes by virtue of being man. If you are a man, then probably because of the makeup of a man, you will be more susceptible to certain diseases that ladies may not have. And the converse is true. So when we're looking at diseases and burdens of disease that attack men, then we know this is a problem of gender. It's a problem of being a man. It can never be experienced by a female. That is the first perspective. The second perspective is the position that they hold in society. And again, as a surgeon, that has connotations in the health-seeking behavior because of the evolutionary nature of our patriarchal society and the position that the man has been expected to hold. And therefore, when I interact with the patient in one way or the other, definitely it will impact how I treat them. Maybe they would come to seek medical attention compared to how often they will bring their child to seek medical attention. So you see that already is some gender bias and discrimination that have been brought into place. So those are the two perspectives that I guess we could delve deeper into these perspectives and see they work.
All right, Dr. So as you've mentioned that men are predisposed by their evolution, nature, and the role they play in the society apart from biology. So in your practice, I'm sure you have witnessed certain patterns and how men handle their personal health. So what are some of these things that you've seen, how men seek what we call health-seeking behaviors?
That's a brilliant and loaded question, Doc. Thank you. Just a while back, some colleagues tried to study in Western Kenya to find out when you find poor health-seeking behavior among men, is there an intervention you could bring in place that will bring them on board? And I will mention that in a short while. But I wanted to say that one of the things that we'll find in men is, for instance, late presentation in seeking care, because that is not the space they have been civilized or socialized to occupy. And there's been a lot of writing about that societal pressure where a man is not supposed to be weak, man is not supposed to cry, man is not supposed to rush to the hospital at the slightest catch of flu. So we used to have an African saying when I was training that an African maid will only seek a doctor's attention if they are in pain or they see blood. So if they suffer without any of those two, they might not go. And that has again been evolutionary. A man was supposed to be the protector, supposed to go look for food and all that, and essentially take care. So they take care of their spouses and their children more and the society more than they take care of themselves. And this has been heavily spoken about. So we see people who do not want to seek attention, or who are late to seek attention because they wanted to wish away these problems until it becomes so serious. And of course that will have detrimental outcome in terms of how it comes, in terms of the treatment outcomes. If they present late, the outcomes are likely to be worse than if they presented early. This is one perspective. The second is risky behavior. Again, according to our social means, if you go to a supermarket down the aisle and you see a lady shopping or a man shopping, maybe they are likely to shop for a gun toy for the boy child and for maybe a nurse model for the girl child. And that is perpetuated down that the boys are supposed to be more adventurous, but that is what is historically there, that the man is supposed to go there, wrestle, fight beast and bring back the hand. And therefore you find people in those brawls because they fight, because of the testosterone. Every day you come in the morning, someone has been attacked with a bottle, they have been cut, and you find that more in men than in ladies. So in terms of violence, interpersonal violence, granted there is some that attracts or affects the ladies, but you'll find a lot of fight in the classroom. It's a problem of the gentleman. When you look at our setup, especially in the African setup, you find that more men probably smoke more, maybe men engage in alcohol more. And all these are some of the risk factors that you will always find discussed anytime you ask the doctor, what are the risk factors for this disease? Be it some of the non-communicable diseases, be it cancer cases, all that. Now the flip side, like I mentioned before, is there are some thoughts about how we can improve the health-seeking behavior of men. And one of them is the paper I was talking to you about, that a study that was done in the Western Kenya, and they said because of the health-seeking behavior, because some of the things that men present as hindrances to seeking intervention could be things around cultural norms, like if there is a lady nurse or there's a lady doctor, I am not comfortable going for a prostate exam, for instance. So these colleagues would set what was called all males clinic or a male health clinic and say we just set a clinic where it is only for males, it is only full of male staff, are we likely to get more men? And they actually found that it was slightly the turn up per population, per capita turn up for seeking health attention was higher if you say this clinic is purely for men. It is purely staffed by men, and it is seclusive. So maybe this is an avenue that we need to maybe...
Was the number significant that might call for an actuation of that?
Yeah, so that's a brilliant question, and I think that will best be left to maybe economists to look at, because yes, scientifically it was statistically significant. But you see the question of what is statistically significant, if it is clinically significant, and if it is generalizable is the question that is out there. Yes. And I think that is something that the people in that space can again explore from that finding and find out, does it apply? Granted, the setting, the cultural setting and the intervention angle was more from the HIV problematic areas and all those prevention of sexually transmitted infections. So maybe the general consultation hasn't been looked at, but I think it is something worth replicating on a larger scale and finding out, especially when we're talking about urology or issues reproductive for men. If having a clinic that is seclusive to men and manned by staff who are just males, we will find the same findings. And if the converse is not true, because you see, you might also find that male might want to go to a female run clinic as well, so we don't have that data yet. Yes. That is an interesting one to follow up and find out.
True. Yes. Please proceed. So the staffing and how it affects the health-seeking behavior. Yes.
Yeah. So absolutely, and whether staffing is male only, that's not the only caveat, because that was the intervention they did by making sure that the staff are all males. But when you blow out that study, and it's something we find time and time again, is that people will always look at the promptness of care, so they don't have delays. They'll look at the quality in terms of the customer care interface with the staff who are there, whether it's really men or ladies, it doesn't matter. So just pointing to that, but there were many other overarching factors that contributed to them seeking that health care, which could mean that by just creating this exclusive clinic, probably you cut out all the other people and therefore you give them more dedicated attention. So there was a lot of overlap of contributors. But I feel as men we need to do more to take on the vulnerability and go to hospital sooner than we are observing currently.
All right, let's hold that thought and we take a break. So we're going to take a break. When we are back, we continue to discuss about the health-seeking behavior of men and much more. So stay tuned.
You are watching TV47, the home of untold stories.
I'm confident that I'm going to get through this and I'm going to find my purpose.
Kijana mtanashati, rangi imeweza. For the biggest of guests, from politicians to entertainers to content creators to whichever kind of a person you want to think that you'd want to see on the show, this is the place to be. Dr. Funeke tonight.
Each and every Wednesday. My name is DJ Lizni, not your ordinary DJ.
And of course, they call me the eagle himself. Your host, Dr. Funeke, is my name. Of course, every Wednesday at 7:30. See you then. Don't touch.
Make sure to join us.
Tell your landlord as well. Jua unalipia parent.
Sikose.
All right, welcome back. You are watching Body Garage, the Art of Wellbeing. I'm your host, Dr. Chapsi. So welcome back to the conversation. So Daktari, is there a difference between the health-seeking behavior of men, let's say, who live in urban areas, maybe a bit more educated, than men who live in the rural areas, maybe not so much educated? Does that have you seen that influencing when they seek services and the outcomes of treatment?
Absolutely. That is correct. And you mentioned two things. One of them is education, and the other one is urbanization. And I feel like the catchment population of the facility where we are at the moment, that is PCA Kikuyu Hospital, is blessed in both ways because there is exposure in terms of urbanization. We are just on the size of the capital. We have all the road network to connect us, and the literacy levels are fairly good in this county and this sub-county to be particular. But from my experience working in rural Kenya, I call myself the village surgeon, I have found that in two fronts. First is that when we educate people, we empower them. When they're educated, they're empowered, both by knowledge, and once they have been educated, they're quickly likely to get white-collar jobs, their income rates are higher, therefore their purchasing of health is enabled. They have insurance, or they have some out-of-pocket ability to achieve. And therefore, it's easier for them to turn up for review in case they have an issue. So the answer is yes. I think from a basic science understanding and from personal experience, that the more educated people are, the earlier it is for them to seek help. And that speaks to whether ladies or gentlemen, and that I have observed. Then you brought the issue of urbanization, and urbanization again has two issues, but the prevalent one is access. Access in two ways. Access that the infrastructure network, the modes of transport is is obviously more developed in the urban centers.
Yes.
In the urban centers, you have all the taxis, you have got all the motorbikes, you can be hailed on the various taxi hailing apps. You don't have that in the rural settings. You've got all the road network, you have rail if you want to mention it, etc., etc. Then you have the provision or the penetration of all the healthcare providers. You work in the private sector, I work in the faith-based sector, there are public sectors around. So people have choice. Per capita of a certain number of population, a certain radius, you will find health facilities. So you see that kind of nearness makes it easy, as opposed to someone in a certain county in Kenya who has to travel maybe 50 kilometers to get to a sub-county facility. Here, all you need to do probably is travel 5 kilometers and you have access to this level of facility. Travel another 5 and you're in a referral facility. So both points that you mentioned contribute heavily to the health-seeking behavior, both directly and indirectly. The final bit which brings a spanner into the works and disrespects these two is the place of culture. And therefore, if you go to rural settings, in that setting you might find someone who is not used to seeking modern healthcare. They have been grown into seeking alternative healthcare, going for Kumganga. So for them, all this fanfare about hospitals and going for scans is neither here nor there. If they have a broken bone, it can be set. When I worked in Meru, we used to receive a lot of patients from the northeastern sides of Kenya. And some of them would come with deformities of the limbs because they had been set to a bone setter after they had sustained some broken bones. And therefore, why is this happening at this day and age? And again, that plays to both how entrenched the cultures are there. Because the more you get urbanized, the more you get cosmopolitan, the more people have lateral thinking and parallel views, and everything just gets mixed up. So there are all those interplays, unless you pick one and exploit to its logical conclusion. All of them, by far and large, contribute to the health-seeking behavior.
All right. And also men tend to think to place their family's needs ahead of self, as culturally, as you said, we've been raised. So if I'm sick right now and I have 100,000 shillings, should I go and treat myself or should I pay school fees? Those are the questions that the men might be asking themselves. Anyway, let's move on, Daktari, to this. So let's pick out 3. Let's talk about prostate, and the colon, and the esophagus. And 3 of those in relation to the habits of men that are men skewed. Alcohol, smoking, and nyama choma. Are they related? Let's start. You will choose where you want to start.
That's interesting. I have not been sent to discredit alcohol. Anyway, we will start one at a time.
Yes.
You mentioned very important top tier cancers that affect males. Because when you look at the statistics that we have, like if you look at the global cancer statistics and come specifically to Kenya, you will realize when you look at men of whatever age, prostate cancer is number one, followed by cancer of the throat or esophagus, and finally by the cancer of the colon rectum, or what we call colorectal cancer. Of course, then stomach follows in the top 5. And all those 5, the top 5 cancers affecting males, other than one of them, all those are dealt with by the surgeon. The other one is a type called non-Hodgkin's lymphoma. Now, the question you've asked is, nyama choma and alcohol and smoking, do they contribute? And I want to start by prostate. And say, prostate, the number one risk factor is just being male. Because females don't have prostates. The same way, not actually even the same way, because at least for breast cancer, men still have breasts, but they're not as affected as ladies. But for prostate, it's 100% in males, 0% in females. And there you can't say alcohol will contribute or nyama choma will contribute. The main thing will be that this person has a prostate. That is like a risk marker. That is a risk marker, and then from there you can add this. So every time we are looking at risk factors for any cancer, we will always assign alcohol and cigarette smoking, because they have been found to contribute to most of these as risk factors. Maybe not directly in most of them, but there are some that you can pick and say alcohol use will lead to this change, which will lead to cancer over a span of decades, but not probably for those that you've identified directly. But all of them are risk factors. Then you've asked nyama choma. Nyama choma, I would say from the latest science I have read that it will be linked directly to any of those cancers. But what you realize is something that we call confounders. That probably the person who is taking nyama choma all the time could be taking nyama choma alongside their drinks. Okay? So when you go for nyama choma, you say, can I puff my cigarette as I'm enjoying my nyama choma? Can I have my bottle of beer as I have my nyama choma? So if you are not having nyama choma, probably they don't go together. If you just having your regular dinner at home, probably you'll have a glass of wine or just a glass of juice or nothing. So that would be how I would link them together. But now if you isolate each and every one of them and find other risk factors, what would this be? We've already spoken about the prostate cancer. The risk is the presence of the prostate. All those, of course, are listed as risk factors that can contribute. And of course, we have a problem called benign prostate enlargement. The prostate enlarges as it continues to enlarge. Some of them, you will pick them having developed cancer. Others will not have cancer. But one of the good things about prostate cancer is it's not as aggressive. Majority of it is not as aggressive. So again, if you pick it early, you are able to manage it, whether radically, depending on how old or young the patient is, or you could sit out, what is called watchful waiting, or or conservative treatment. So that's for prostate cancer.
Before you skip, for prostate cancer, it can catch up almost in any age, but there is a certain point where you actively start looking for it as a surgeon. At what age should men now start looking at their prostate health carefully?
That is a brilliant question, Doc. And first and foremost, I would just tell people, adopt annual screening for all health parameters, irrespective. And then it can be cancer, it can be whichever health problem. Then to come to the prostate, we will say, mostly in most of the setups, at 40 years, you start getting active screening for this. And the screening, there are various ways. Of course, you will be seen by the doctor. They will do some examination. They might order some tests, and then they might order some scan on just the exam itself will be sufficient. When you look at the various populations, certain populations will have different cutoffs for age at which you are recommended to have routine serious screening. But if the person has family history of cancer, then of course that bracket comes down. And it's upon you and your doctor to discuss and say, my father or my brother had prostate cancer at age 40. Therefore, we can't tell you to wait to 40.
Yes.
We'll have to start earlier, etc., etc. So to answer your question, if I was to give a cutoff, start at 40. But of course, get advice from the doctor. We can vary it downwards if the risk profile is slightly higher. Yes.
All right.
Yes.
Let's talk about the other two.
Great. So the other we want to talk about is the cancer of the esophagus. Again, fairly common, especially in our setup, and especially when you go to the Far East. And various risk factors have been put there. Again, alcohol comes. Again, smoking comes. Depending on which type of this cancer that you have. If it's the type that we call squamous cell, then we find a different risk factor. If it's a type that we call adenocarcinoma or adenocarcinoma type, then we find that the risk profile is not just those two we have mentioned. We have other risks, especially if patients have got constant heartburn and what we call reflux disease. Reflux disease is where the junction between the food pipe or the gullet and the stomach is not tight enough. There's supposed to be what we call the cardiac sphincter is not tight enough. So you will realize that the contents of the stomach, which is strong acid,
TV47, the home of untold stories. Tonight,
whenever as a people we have come together, we have always found a solution even to our worst problems. This time will be no different. We believe that in the end, it is the people's voices that will prevail.
Azimio leaders set to hold a public baraza at the Kamukunji grounds next Tuesday.
In the run-up to the voting on the finance bill, various polls showed that more than 90% of Kenyans rejected the finance bill.
The leaders say they will announce the next course of action next week. Also tonight, senators marveled with a 1 million chair allegedly bought by the Siaya County government.
I don't interface with the CFO when it comes to payments.
Embattled Siaya deputy governor says he did not play a role in the procurement process. Plus,
wakaanza kurudi tena katika kufanya adjustment kwa hesabu zao. Wakanitumia email tena kusema kwamba sasa tunakudai 292,000.
we shall tell you about a tailor in Turkana County who Kere says he owes the authority 1.7 million shillings in tax arrears.
You are watching TV47, the home of untold stories. Welcome to the Mwai Kibaki Convention Center, the premier events venue. Our state-of-the-art facilities are designed to meet all your needs, from large-scale conferences to intimate meetings and everything in between. Located in the heart of Thika, the Mwai Kibaki Convention Center offers stunning views of the city skyline and is easily accessible from all major transportation hubs. Our facility features ample parking, free Wi-Fi, advanced audiovisual equipment, and our technical team is always on hand to ensure your event runs smoothly and seamlessly. Don't take our word for it. Make your next event unforgettable at the Mwai Kibaki Convention Center. Contact us today for bookings and reservations. Email multimedia@mku.ac.ke or call us on 0708 212204 or 0727 441733 or 0721 438 629 to learn more about our services and book your event.
I am so excited to have joined MKU. The flexibility in the payment of fees makes education very affordable.
With over 165 fully accredited programs and the state-of-art learning facilities, you literally have the world in your hands in terms of career choice.
The learning is not only uninterrupted, but also supported through ICT. And within no time, you're done with your studies.
Join us and start your career journey.
Intake is in progress. Mount Kenya University, unlocking infinite possibilities.
Mount Kenya.
You are watching TV47, the home of untold stories.
Welcome back. You are watching Body Garage, the art of well-being. I'm your host, Dr. Chepsi. We are on the conversation of men's health from the surgeon's perspective, and now we want to talk about the colon cancer. Yes, Dr. You have talked to us about the prostate cancer, the cancer of the food pipe or esophageal cancer. Educate us about the colon cancer now.
Thank you. Maybe briefly is to say, like I mentioned, is among the top causes of cancer problems in the country. When we sum up all the cancers together, we could say that colon cancer would take 6 to 7 people per 100. If we take 100 people with any cancer in Kenya, in one room, 6 to 7 of them are likely to be those suffering from colon cancer. Of course, others you can assign to others. We are starting with the prostate being on the top. Now, colon cancer, we had already mentioned a few risk factors earlier on. And I think I wanted to take this time just to mention a few things about how the patient might present, some of the things they need to be on the lookout for, and then how to follow them up. So one of them is usually just some discomfort, abdominal discomfort most of the time. Patient comes, when they eat, they just feel some discomfort, they feel like they bloat. Sometimes they go for a long call and they struggle to get the long call. At times they go for a long call, it's hard, and then the next day they go is a little more watery. We call that all-time bowel habits. All-time bowel habits. They have constipation, interspersed with diarrhea. They have unspecific abdominal discomfort. If that advances further, they start developing certain symptoms that in the medical fraternity, like we call the B symptoms. So these are not specific symptoms to that disease, but someone just feels sick, they feel weak, they are losing weight, they are sweating at night, they run in temperatures. These are what we call B symptoms, constitutional symptoms. Some of them might present with some alterations in the color of stool or direct blood yes. Go for a long call. So all these are some of the things you look out for when you tell the doctor, so that they're able to quickly identify what is the problem. In the early stages, of course, the doctor will be able to examine and tell you if they can find something on their clinical exam, but we also do some endoscopy procedures, and I know you've interviewed some colleagues who do that more frequently than I do. I will do that here, and it's a test called colonoscopy. So you're able to advance a scope up the entire large intestines. It's a telescope as you see on the screen, and if you find a swelling, you can take some tissue, take to the lab, and you're able to confirm. Once that is confirmed, then you're able to know how to treat it based on how aggressivity has been. Again, what I will say is, people, if such symptoms come to you, don't just see it, don't just be okay being told, okay, this is typhoid, or this is brucellosis. No, if the first treatment is not working, if the second treatment is not working, seek a second opinion, because it is.
And is that the thing with that happens with many of patients with the cancers of the intestines, or the food tract all the way up, down, that they have been seen somewhere else over and over, and they're told gastritis, for example, that is, or typhoid, or let me use Kiswahili. Some will say, mina kuanga na acidity too. Is that the case that's happening, so that by the time things turn serious, it's already late?
remember the time they call it H. pylori. Anyhow, yeah, absolutely. What you mentioned is absolutely true. In my book, I think I describe such a case. Someone has been for almost 5 years. They are told you have typhoid, you have acidity, you have H. pylori, but it's because the level and the expertise that they are exposed to does not discern better. And therefore, if you are seen by maybe a fairly junior colleague who does not discern that, okay, I need to escalate this, then you can't really blame them because they could not perceive that there's likely something more dangerous lacking inside. So the more training we have, the more we have doctors in the farthest corners of the country, the more we are able to pick this earlier. And also for the patients themselves to stop doctor shopping. Today they are here, tomorrow instead of coming back and telling me this medicine you give me doesn't work, they go to Dr. Chepsi, who starts from a scratch. Sometimes they won't reveal all the information. They go to a certain Dr. X, and then sometimes they go into denial. You tell them, I am starting to suspect something. Instead of us continually treating this, I want to send you for this test. Then they disappear for 2 years. Then they resurface. I've had such a patient. They disappear, they go around, and then you meet them in another corner. And you're like, but I saw you in a facility X and I told you to do 1, 2, 3. Where have you been? So there are a lot of factors that you have to do. But what you observed is absolutely correct. It is so sad to see a patient with advanced stomach cancer who has been treated for gastritis for years when it just needed to be submitted to endoscopy and for us to have that diagnosis added.
All right. So apart from the physical examinations and the follow-up, it seems like endoscopy, colonoscopy plays a big role in early detection of these tumors that can be in the esophagus or the stomach or the colon or the rectum. Right?
Absolutely.
So in a normal person, how frequently should I undergo endoscopy?
Actually, in a normal person, we have not gotten to the point where we've given mandatory guidelines that if you are normal, you have no problem, go for routine endoscopy. We haven't gotten that. I know there are countries in this world who have got high rates of these cancers who have said beyond this point, it is mandatory population screening. From the best of my understanding, what we have now is symptom-based screening, where you've come for wellness, and what the doctor is doing at that point is actually to listen to you and ask you, how is your health like? Are you eating well? Are you having anything unusual about the body? And that's when you tell them, every time I eat, I have this acidity that does not end. That is where now the endoscopy will be introduced. Or I feel like I'm weak all the time. And then the doctor does maybe a stool analysis and they find some occult blood, what we call occult blood. It's a little blood in the stool. And they say this person could be bleeding somewhere. So you see, the moment you expose yourself to a well-trained doctor by way of normal wellness screening, they know the right questions to ask for them then to say, listening to your family history, looking at your demographic, looking at where you come from, and my understanding of the disease profile and distribution across these points, I recommend you to have this and this and this. So once you have that, it is easier to pick. Absolutely easier to pick. As opposed to if you prescribe discriminately, because it then is going to be very expensive and it might not be helpful for the patient.
True. Let's say I have done one endoscopy and maybe there was just mild what we call mild ulceration or gastritis, features of gastritis. How then should I approach that? How frequently should I put in mind that I need a follow-up?
I see. That's a nice question. I don't want to give a prescription because people will disappear from their follow-up because of watching the show. But what I will say is follow your doctor's instructions. Because again, we don't have a cookbook where we say, you have this, go this direction. You have this, go this direction. Everything is still up to the patient. But if all that is found is gastritis, the doctor will treat the gastritis. If there are contributing factors or risk factors and all those other causes that the doctor will find, he will eliminate them, they will initiate treatment, they will tell you come. Maybe it will be 6 weeks time after a certain course of treatment, and then when you come, there's a regimen on how they are going to assess. They may not repeat the endoscopy at that point, whatever they find might demand a repeat endoscopy. All those now are tailored down to specific patients based on their profiling in terms of all the risks, whether family, whether personal, whether environmental. And therefore, I wouldn't want to give a blanket answer because they may be a little misleading. But when a doctor is able to pick that, they're able to tell you, this is what you have, come within this time. And then after that review, they're able to advise further.
Exactly.
Yes.
All right, let's talk about the numbers a bit. We picked out these 3 cancers, the prostate, colon, and the esophagus. What is the landscape like in Kenya?
So that's an interesting one, and I will share with you and the team the people we keep referring to, which is the Global Cancer Report of 2020 that looked at the numbers that we have. But if you look at the population of Kenya and say we have 53 million, this is statistics, which of course keep changing every day depending on the methodology you apply, depending on the new cases being handled, is that, you know, you could be having up to 42,000 new cases out of that. And out of those, in a 5-year span, you could be having up to 82,000 cases. And as you break them down, then you can see which of these, and those are the total cancer cases I'm talking about. And if you break it down, then you're able to say if it is for the cancer of the esophagus, it is this much out of these total cases.
So, sorry, 82,000 cancers, all types of cancers per year?
All lumped together.
Per year?
No, over 5 years.
Over 5 years, all right.
Yes, yes. And if you want to bring it and say how many number of new cases do we have, for instance, when they looked at all this data and said the number of new cases maybe in this year, this report was about 42,000. Again, this is an estimate that is several months old, and this is an estimate that did not look at all the centers in Kenya, because when you look at the reporting, probably not all the centers in Kenya were reporting these numbers. You might find that there were certain centers of excellence in certain corners of the country, but probably those do not cover all the counties, and the diagnosis was not specific. So this is a drop in the ocean, or an iceberg, a tip of the iceberg, in terms of the real picture. I may not have the data for the facility at the moment, but it is a fairly prevalent problem, cancer as a body.
Is the prevalence, or should I say the incidence of cancer increasing? Like, are we having more people with cancer? Generally speaking?
Generally speaking, yes. The question is to dissect the figure and decide what to do with it. But what we've seen is 2 points. One, both prevalence, which means all number of cases, and incidence, which means number of new cases.
New cases,
which means new ones today, or all that have been there in the population, are increasing. And the other thing we keep observing, irrespective of the cancer, is that younger and younger and younger people are being affected by cancer. And therefore, if you look at those, you ask yourself one question. Is it that we are now screening more, investigating more, and our patients are coming, our people are coming to hospital more than they were doing before? I hope that is the situation. I hope that's the situation, but that isn't something I'm not able to answer at the moment. Because when you look historically, people will tell you, oh, he died, he must have been bewitched. How could he just die like that? But you see, they had gone to hospital and gotten all this extensive investigation. Those days, probably it was early advanced cancer that came to them. So it could be that there's a lot of uptake of health-seeking
behavior,
and therefore we are picking the cancers
earlier. Okay, all right. Yes. Now, if we can leave the numbers, let's come to the boardroom now.
Which boardroom?
You've served in different capacities in health leadership and health management, and I think that gives you a hand to have a say when it comes to now about management in health. And in this case, we are talking about the surgical services, right? And cancers and the related. What is the burden like? First of all, how many surgeons are there in Kenya? In your specialty specifically?
We could talk about this for a year. Could run our conference just discussing that. But this is the space of global health. or what we call global surgery, where I am actually pursuing my doctorate. And we talk about the access to surgery in two fronts. One is the duration someone has to travel to get access to a facility that can do the surgery. The second bit is the population of surgical providers per capita, per total number of people in Kenya. And I want to touch on the second bit, which is what we've mentioned. And mentioned that we are doing very badly as a country. The data we have, both modeling and real data from Kenya, is that the projection from the Lancet Commission, which was a big commission that was looking at how we can give all the resources, including the human resources, to health to achieve adequate surgical care delivery, projected that for every 100,000 population, we should have 20 surgeons, obstetricians, and anesthesia care providers. That can
for every 100,000
surgical service provider. For every 100,000, we should have 20 of those. When you look at the Kenyan population, we have 2.3 per 100,000. So that
two surgeons.
2.3 surgery and anesthesia providers. We lump them together, surgery and anesthesia providers. So that means a surgeon, a gynecologist, or an obstetrician, and an anesthetist. To lump them together so that we can reach that. And those are the figures we have. If you look, of course, at the medical board, the rate is going to be low for surgeons. If you look at the WHO recommendation of 1 doctor to 1,000 people, the Kenyan statistics, last I checked, were awfully not even, were 10 times less that or more. So we are doing badly from that front. And if there's one clarion call we can make is we need more. Once you say we need more, you can branch it. We say we need more human resources for it, we need more infrastructure, we need more funding, we need more health system strengthening. All those we need more and more and more to make surgical services available.
Wow.
Yes.
That's quite sad. And I think as we wrap up, will that be the case contributing, because in some facilities, especially in the public facility, you will go, you have your relative who is sick but has been queued for a surgery that is, he or she is scheduled in the next 2 months.
You are lucky if it's 2 months. I think there are 6 months. There are 6 months and even a year. But that is absolutely the case. And it is again the issue of we need more. So if we are not harmonized, we have a situation where you have a surgeon, but you don't have a theater. Or you have 3 surgeons, you have an ENT surgeon, you have an orthopedic surgeon, you have a general surgeon, you have another surgeon. And the theater available is maybe 1.
Just 1.
And then the theater space is not corresponding to the population. So there are all manner of things. The moment you staff them, then equip them, then give them infrastructure in terms of theaters, then the waiting times comes down. So that is absolutely in order, but it is again a confluence of several things. It could be the supplies that don't arrive on time. You know, it could be the supplies that don't arrive at time. So surgeons are there, they come, they want to operate, and then the patients are cancelled because the switcher is not available, the certain drug that's not available, and the procurement is taking time, there's a machine that has broken down, etc., etc., etc. So every time we listen to a case, it is specific to different counties, specific to different institutions, but by and large, we have a mixture of all of them. We have new hospitals with fantastic looking theaters, probably with equipment, but we don't have trained personnel to handle them, so it doesn't contribute to that. We have areas where people have been trained, they have come back from training, they are available, but there's no theater, or there's no image intensifier, or there's no anesthetic machine, or there's another critical missing person like an anesthetist when the surgeons are there. It's just kind of a mix-up of things, and you have to isolate case by case and see what is missing.
All right. Yes. Thank you so much. I think we will stop there. There's a lot to talk about, and time is a limiting factor in this case. So I would like us to come to the conclusion in 10 seconds. Please speak to the people, speak to the men about their health.
Happy Father's Day, men. Your health is your wealth. If you feel unwell, don't act strong. Just go to hospital, let the doctor check it. It could be something small, it could be nothing, you just get reassured, but it could also be a vital step for you to get discovered early and cured of a very, very dangerous disease. I wish you well. Thank you and goodbye.
All right, thank you so much for watching this show this far. And I trust that you have learned a thing or two about men's health, especially things that concern the surgeons. And I trust that you will make better decisions and be able to be checked as early as possible. My name is Dr. Chepsi. I've been your humble